First cholera pandemic, 1817 to 1824, also known as the First Asiatic Cholera Pandemic or Asiatic Cholera, began near the city of Calcutta, and spread throughout Southeast Asia to the Middle East, Eastern Africa and the Mediterranean coast. While cholera had spread across India many times previously, this outbreak went further. It reached as far as China and the Mediterranean Sea before subsiding. Hundreds of thousands of people died as a result of this pandemic, including many British soldiers, which attracted European attention. This was the first of several cholera pandemics to sweep through Asia and Europe during the 19th and 20th centuries. This first pandemic spread over an unprecedented range of territory, affecting almost every country in Asia. Cholera was endemic to the lower Ganges River. At festival times, pilgrims frequently contracted the disease there, and carried it back to other parts of India on their returns, where it would spread, then subside. The first cholera pandemic started similarly, as an outbreak that was suspected to have begun in 1817 in the town of Jessore. Some epidemiologists and medical historians have suggested that it spread globally through a Hindu pilgrimage, the Kumbh Mela, on the upper Ganges River. The second cholera pandemic, 1826 to 1837, also known as the Asiatic cholera pandemic, was a cholera pandemic that reached from India across Western Asia to Europe, Great Britain, and the Americas, as well as east to China and Japan. Cholera caused more deaths, more quickly, than any other epidemic disease in the 19th century. The medical community now believes cholera to be exclusively a human disease, spread through many means of travel, and transmitted through warm fecal contaminated river waters and contaminated foods. During the second pandemic, the scientific community varied in its beliefs about the causes of cholera. Although not much is known about the journey of the cholera pandemic in East India, many believe that this pandemic began, like the first, with outbreaks along the Ganges Delta in India. From there, the disease spread along trade routes to cover most of India. By 1828, the disease had traveled to China. Cholera was also reported in China in 1826 and 1835, and in Japan in 1831. In 1829, Iran was apparently infected with cholera from Afghanistan. The third cholera pandemic, from 1846 to 1860, was the third major outbreak of cholera, originating in India in the 19th century, that reached far beyond its borders, which researchers believe may have started as early as 1837 and lasted until 1863. In Russia, more than 1 million people died of cholera. In 1853-54, the epidemic in London claimed over 10,000 lives, and there were 23,000 deaths for all of Great Britain. This pandemic was considered to have the highest fatalities of the 19th century epidemics. It had high fatalities among populations in Asia, Europe, Africa, and North America. In 1854, which was considered the worst year, 23,000 people died in Great Britain. That year, the British physician John Snow, who was working in a poor area of London, identified contaminated water as the means of transmission of the disease. After the 1854 Broad Street cholera outbreak, he had mapped the cases of cholera in the Soho area in London, and noted a cluster of cases near a water pump in one neighborhood. To test his theory, he convinced officials to remove the pump handle, and the number of cholera cases in the area immediately declined. His breakthrough helped eventually bring the epidemic under control. Snow was a founding member of the Epidemiological Society of London, formed in response to a cholera outbreak in 1849, and he is considered one of the fathers of epidemiology. The fourth cholera pandemic of the 19th century began in the Ganges Delta of the Bengal region, and traveled with Muslim pilgrims to Makkah. In its first year, the epidemic claimed 30,000 of 90,000 pilgrims. Cholera spread throughout the Middle East, and was carried to Russia, Europe, Africa and North America, in each case spreading, via travelers from port cities and along inland waterways. The pandemic reached northern Africa in 1865, and spread to sub-Saharan Africa, killing 70,000 in Zanzibar in 1869-70. Cholera claimed 90,000 lives in Russia in 1866. The epidemic of cholera that spread with the Austro-Prussian War of 1866 is estimated to have taken 165,000 lives in the Austrian Empire, including 30,000 each in Hungary and Belgium, and 20,000 in the Netherlands. The fifth cholera pandemic, from 1881 to 1896, was the fifth major international outbreak of cholera in the 19th century. It spread throughout Asia and Africa, and reached parts of France, Germany, Russia, and South America. The 1892 outbreak in Hamburg, Germany was the only major European outbreak. About 8,600 people died in that city. Although many residents held the city government responsible for the virulence of the epidemic, leading to cholera riots in 1893, it continued with practices largely unchanged. This was the last serious European cholera outbreak of the century. During the pandemic, Robert Koch isolated Vibrio cholerae and proposed postulates to explain how bacteria caused disease. His work helped to establish the germ theory of disease. American author, Mark Twain, an avid traveler, visited Hamburg during the cholera outbreak, and he described his experience in a short, uncollected piece. The sixth cholera pandemic, from 1899 to 1923, was a major outbreak of cholera beginning in India, where it killed more than 800,000 people, and spreading to the Middle East, North Africa, Eastern Europe and Russia. According to Leonard Rogers, following an outbreak of cholera at the Haridwar Kumbh Mela, the epidemic spread to Europe via Punjab, Afghanistan, Persia, and southern Russia. Waldemar Mordecai Wolf-Hafken, a bacteriologist from Russian Empire, who worked at the Pasteur Institute in Paris, where he developed an anti-cholera vaccine that he tried out successfully in India. He is recognized as the first microbiologist who developed and used vaccines against cholera and bubonic plague. He tested the vaccines on himself. The seventh cholera pandemic was the seventh major outbreak of cholera, and occurred principally from the years 1961 to 1975. This pandemic, based on the strain called El Tor, started in Indonesia in 1961 and spread to Bangladesh by 1963. Then it went to India in 1964, followed by the Soviet Union by 1966. In July 1970 there was an outbreak in Odessa, and in 1972 there were reports of outbreaks in Baku. It reached Italy in 1973 from North Africa. Japan and the South Pacific saw a few outbreaks by the late 1970s. In 1971, the number of cases reported worldwide was 155,000. In 1991, it reached 570,000. The spread of the disease was helped by modern transportation and mass migrations. Mortality rates, however, dropped markedly as governments began modern curative and preventive measures. The usual mortality rate of 50% dropped to 10% by the 1980s and less than 3% by the 1990s. The third plague pandemic was a major bubonic plague pandemic that began in Yunnan, China, in 1855 during the fifth year of the Xianfeng Emperor of the Qing dynasty. This episode of bubonic plague spread to all inhabited continents, and ultimately led to more than 12 million deaths in India and China, with about 10 million killed in India alone. According to the World Health Organization, the pandemic was considered active until 1960, when worldwide casualties dropped to 200 per year. The name refers to this pandemic being the third major bubonic plague outbreak to affect European society. The first was the Plague of Justinian, in 541 and 542. The second was the Black Death, which killed at least one-third of Europe's population in a series of expanding waves of infection from 1346 to 1353. The plague, which was brought from Hong Kong to British India, killed about 1 million in India. It later also killed another 12.5 million in the British colony India over the next 30 years. Almost all cases were bubonic, with only a very small percentage changing to pneumonic plague. The disease was initially seen in port cities, beginning with Bombay, but later emerged in Pune, Calcutta and Karachi. By 1899, the outbreak spread to smaller communities and rural areas in many regions of India. Overall, the impact of plague epidemics was greatest in western and northern India, and eastern and southern India were not as badly affected. The Spanish flu, also known as the 1918 flu pandemic, was an unusually deadly influenza pandemic caused by the H1N1 influenza virus. Lasting from spring 1918 through spring or early summer 1919, it infected 500 million people, about a third of the world's population at the time. The death toll is estimated to have been anywhere from 17 million to 50 million, and possibly as high as 100 million, making it one of the deadliest pandemics in human history. The outbreak was first observed in Haskell County, Kansas, USA, in January 1918. The Spanish flu infected around 500 million people, about one-third of the world's population. Estimates as to how many infected people died vary greatly, but the flu is considered to be one of the deadliest pandemics in history. The disease killed in many parts of the world. Some 12 to 17 million people died in India, about 5% of the population. The death toll in India's British-ruled districts was 13 million. In Japan, 23 million people were affected, with at least 390,000 reported deaths. In the Dutch East Indies, now Indonesia, 1.5 million were assumed to have died among 30 million inhabitants. In Iran, the mortality was very high. According to an estimate, between 902,402 million 431,000, or 8% to 22% of the total population died. In the US, about 28% of the population of 105 million became infected, and 500,000 to 850,000 died. In Brazil, 300,000 died, including President Rodrigues Alves. In Britain, as many as 250,000 died, in France, more than 400,000. In Ghana, the influenza epidemic killed at least 100,000 people. The pandemic mostly killed young adults. In 1918 to 1919, 99% of pandemic influenza deaths in the US occurred in people under 65, and nearly half of deaths were in young adults 20 to 40 years old. The second wave of the 1918 pandemic was much more deadly than the first. The first wave had resembled typical flu epidemics; those most at risk were the sick and elderly, while younger, healthier people recovered easily. By August, when the second wave began in France, Sierra Leone, and the United States, the virus had mutated to a much more deadly form. October 1918 was the month with the highest fatality rate of the whole pandemic.
Coronavirus disease 2019 or COVID-19 is an infectious disease caused by the virus severe acute respiratory syndrome coronavirus 2. The disease was first identified in Wuhan, the capital of China's Hubei province, in December of 2019. Since then, it has spread around the world and resulted in a global pandemic. The most common symptoms of COVID-19 infection are fever, cough and shortness of breath. But other symptoms can occur too, including the loss of smell, a sore throat, muscle pain, a wet cough, diarrhea and abdominal pain. Most cases are mild and do not need hospital care. However, some COVID infections will lead to viral pneumonia and the failure of the respiratory or other body systems. For those cases, hospitalization is frequently needed for breathing support, with oxygen or a mechanical ventilator, along with therapy to support the circulatory system, kidneys, and other body systems. As of 4 May 2020, more than 3,580,000 cases have been reported in 187 countries and territories, resulting in over 251,000 deaths. More than 1.16 million people have recovered. The virus is mainly spread during close contact, and by small droplets produced during coughing, sneezing, or talking. Close contact is defined as 1 meter or 3 feet by the World Health Organization and 2 meters or 6 feet by the United States Centers for Disease Control. The small droplets of infected sputum can also be produced during breathing, but fall rapidly to the ground or surfaces, so they are generally not thought to be able to spread COVID-19 over large distances. The infected droplets can survive on surfaces for up to 72 hours, and spread when a person touches a contaminated surface and then their face. The average time from exposure to onset of symptoms is 5 days, but it can vary from as little as 2 days to as many as 14. The standard method for diagnosis of active COVID-19 infection is with a swab of the back of the nose and back of the throat, which is then tested for the virus using a reverse transcription polymerase chain reaction or PCR process. The infection can also be diagnosed from a combination of symptoms, risk factors, and a chest CT scan showing features of pneumonia. The recommended measures to prevent infection include frequent hand washing, social distancing, covering coughs and sneezes with a tissue or inner elbow, and keeping unwashed hands away from the face. Social distancing involves maintaining a physical distance from others and has been a key tool used by communities to slow down the intensity of the pandemic. The use of a surgical mask is recommended for anyone suspected of having the virus to prevent the spread of infected droplets. Caregivers should also use masks, face shields, and other personal protective equipment when caring for people with active COVID-19, and high-filtration masks, like the N95, for any activities that may generate aerosol from an infected patient. Recommendations for and against mask use by the general public vary by country and region. Currently there is no vaccine or specific antiviral treatment for COVID-19. Management involves treatment of symptoms, supportive care, isolation, and experimental measures with hospitalization for severe cases. The World Health Organization declared the 2019-20 coronavirus outbreak a public health emergency of international concern on 30 January 2020, and a pandemic on of March 2020. Local transmission of the disease has been recorded in most countries across all 6 WHO regions.